Welcome to the Spoony Struggle. This is your host, Jessica. I'm a neuropsychologist and longtime spoonie with Ehlers Danlos, POTS, and a whole host of other syndromes. This show is about the raw, honest look at living life with chronic illness and pain, especially those that are difficult to diagnose and less well known and understood. Full disclosure, any information discussed in this podcast is strictly the opinion of the host and of the guests and is for informational purposes only. It is not meant as medical advice and should not be taken as such. Always consult with your doctor and medical team. Living with chronic illness can be hard. If you ever find yourselves or someone you love in crisis and need someone to talk to, you can always call the National Suicide Hotline Support Lifeline at 1-800-273-TALK. They offer free and confidential support in the USA 24/7. And now, the Spoony Struggle. Hello and welcome to the Spoony Struggle. This is your host, Jessica. Today we talk all about Ehlers Danlos Syndrome. So this is the first in a series discussing basic ins and outs of a lot of these invisible chronic medical conditions that are on the rare side that take unfortunately a long time to get diagnosed because they're misidentified or misdiagnosed, but are really, really important to catch. Therefore, I wanted to start talking about them. So what exactly is Ehlers Danlos Syndrome? So it's actually a group of connective tissue disorders that is inherited. So everyone's can look a little bit different. So let's say somebody has hypermobile EDS. Well, their hypermobile EDS might look different than the next person's hypermobile EDS. As you heard with my story and with Lewis's story, we both have hypermobile EDS, but it looks different. There are also different genetic causes. So other than hypermobile EDS, which we really just don't know exactly what the gene is, or it may be different genes, they're still looking, there are different genetic causes for each of the different subtypes. Right now, there are 13 subtypes, although I've heard that they're looking at a 14th, 15th, and possibly 16th subtype. So honestly, we just don't know enough about it. So what exactly is Ehlers Danlos? It's generally characterized by joint hypermobility, which means joints that are just really stretchy. They go further than they should. Skin hyperextensibility, which means stretchy skin, although it doesn't have to be super duper stretchy, just at least mild. And fragile tissues. To diagnose these 13 different subtypes, or 14 or 15 or possibly more, there is a set of clinical criteria, which there's new criteria since 2017, and it outlines what to look for. So you have to match up the person's physical signs and their symptoms with what they call major, like the most important, and minor criteria. So the smaller things, but are still necessary. There is a lot of overlap. So a lot of times, as we'll talk about in a few minutes, people do need actual genetic testing to try to figure out what's what, because it's not always super easy to find out. And actually, each type of Ehlers Danlos syndrome is thought to be an actual distinct problem in the connective tissue. So what exactly is connective tissue? So that's what the body uses to provide elasticity or stretchiness and strength, so how strong you are. When a person has normal connective tissue, it tends to hold these proteins that allow the tissue to be stretched, but reasonably stretched, not overstretched, not stretched beyond its limit, and then it goes back to normal. So it's what it should do. But that doesn't happen with Ehlers Danlos. It's overstretched and it doesn't always go back to normal. And since connective tissue is found throughout the body, Ehlers Danlos is a whole body syndrome. It's something that affects all the structures of the body. So let's say somebody builds a house, and they build a house with shoddy materials or faulty materials that don't really do what they're supposed to do. So let's say it's half the wood that they need and soft aluminum nails that aren't going to hold. You know there are going to be problems. Some problems are more likely to show up than others, but because the materials were used everywhere and just aren't really viable, there will be some sort of problem. And we don't know how serious it is, but something's going to happen. Same thing with Ehlers Danlos and connective tissue. Who are the famous people that have Ehlers Danlos? Well, Jamila Jamil from The Good Place, Evie Oddly, and it looks like Lena Dunham as well. Now, what are the symptoms of Ehlers Danlos? As I said before, it really varies on the person. everyone is different, and there are some things that are more common, some things that you have to have in order to get a diagnosis, and then others that are really hit or miss for the person. So it always affects the joints. So there's joint hypermobility, there's the skin hyperextensibility, as I mentioned before, and there's the fragile tissue, but past that, it tends to vary. A lot of times there's pain of the different joints in the body. People can get early onset arthritis, a lot of times in their 20s and 30s. People can have pain in the neck, just like Lewis and I have. They can have difficulty walking for lots and lots and lots of different reasons. They can have numbness and tingling of the hands and the feet, so some sort of neuropathy, some sort of dizziness, swallowing difficulties, changes in speech. They can find that there's looseness or instability around the head and neck, just like Lewis and I have with the possible craniocervical instability and the atlantoaxial instability, which we'll talk a little bit more about in a few minutes. Sometimes people have an abnormal curvature of the spine, somewhat like a scoliosis or something like that, especially because the structural aspects of the body just aren't sound. They often have poor proprioception, so they don't really know where they are in space or how strong to be holding something versus how loose to be holding something. So for example, for me, I tend to drop my pencils because I can't feel them. So what do? I overcompensate by having a death grip on it. Lewis is the opposite. He doesn't realize how strong he is, and things tend to break around him because he's using things at what he thinks are a normal amount of strength, but it's too much and things break. So again, poor proprioception. The skin, in addition to being really fragile, it can bruise really easily, which may actually be severe bruising. There can be severe scarring or atrophic scarring, so the kind of that raised scarring. There's often that soft, velvety-like skin. The wound healing is not as good, so it's slow. There can be little, what they call molluscoid pseudotumors, which are flesh lesions associated with scars over pressure areas. Often people have stretch marks, and these are not necessarily the same stretch marks as one would expect during pregnancy, and actually men can get them too. So it's not gender specific. These tend to occur without rapid weight gain. This doesn't have to be related to weight gain at all. And a lot of times these can happen earlier, so during adolescence or early 20s. People have hernias. Actually, that is a pretty common thing to have happen. And one thing that I think I forgot to mention in my story is in, I think, 2008, 2009, I was found to have a hernia. And I think I've actually had two. I've had a hiatal hernia and what they call a spigelian hernia. So kind of cool name. Some of the other possibly less common but still happen types of things are some sort of rupture. So that could be arterial, intestinal, uterine. There could be scoliosis, and that can actually occur at birth depending on the type of Ehlers Danlos. Again, depending on the type, there could be some sort of poor muscle tone. Mitral valve prolapse can occur, and we'll talk a little bit more about the heart in a little bit. Gum disease or issues with the teeth are really common. So let's talk about GI. So pretty much anywhere along the GI tract can you find problems. So there can be reflux/heartburn. There could be abdominal pain, bloating, irritable bowel, diarrhea or constipation. There can actually be bowel incontinence. There could be hernias, internal organ displacement, rectal prolapse, unfortunately gut perforation, nausea, gastroparesis, and that's just the stomach not emptying or emptying very, very slowly. You can also have difficulties, including the mouth, so difficulty with chewing and swallowing. So really anywhere along that GI system can you have problems. Headache and migraines tend to be more common. And going back to the gums, I mentioned the gum issue before, but TMJ, bleeding gums, gum recession, gum disease, really teeny or none at all of the frenula, which is the little connective flap right between the front of the gums and the lips. The teeth can be deep and pointed. The teeth can have shortened roots. It can be abnormal enamel, tooth fractures. Dental anesthesia might actually not work, and rapid orthodontic correction. Some other things include easy wounding with oral appliances, which is sometimes why they prescribe an ALF instead of one of those bigger mouth devices. And I won't get into an ALF today, but that's something that you can look up. The lining inside the mouth is often thin and fragile. And like with the rest of the body, if there's a wound, then it might bleed excessively or there might be poor wound healing. That's something that's not exclusive to the mouth. It can happen anywhere in the body. And unfortunately, there's often early onset gum disease in some EDS patients. Much like there are GI issues, there can also be urinary issues. So people with especially hypermobile EDS can have urinary incontinence, urinary tract infections, some sort of urinary reflux, or difficulty with voiding. Sleep disturbance is also really, really common. So that could be difficulty falling asleep. Really poor sleep architecture is common, but there can also be sleep apnea and or narcolepsy. There are also some other things that are associated with it. So Lewis and I already talked about the atlantoaxial instability and the craniocervical instability, but I'll talk about that a little bit more, and then I'm sure we'll have another episode specifically on that. So the atlantoaxial instability is that weeble-wobbly instability of the atlas and the axis up in the C-spine. And when those ligaments are really loose and the joints are really overly movable, then you can have some problems. So you can have headaches, limb weakness, trouble with movement, all those kinds of things, which are really not great. So a lot of times people will wear a neck brace, much like Lewis and myself, do physical therapy, and avoid activities that'll kind of make those things worse. Sometimes people can get surgery, but as Lewis mentioned, you have to be really careful about who you go see. Craniocervical instability is similar. So a little bit lower down than the atlas and the axis is where you'll find the craniocervical instability. So again, it's that loose ligament type of a thing that affects the neck and the area from the skull to the spine. So people who have damage there might have trouble with moving or be slow to develop those moving skills. They might have poor coordination, cognitive difficulties, headaches, nausea, weakness in their limbs, clumsiness, things like that. Tethered cord is also pretty common, and that's one of the reasons that people will notice bladder incontinence is actually from tethered cord sometimes. So tethered cord is actually talking about the spinal cord, and that's when the spinal cord is attached to the tissue around the spinal cord that tends to pull on or make longer the spinal cord and make it really, really tense or taut. This, as you might expect, leads to not so great symptoms like low back pain, loss of bladder control, lower body or leg weakness, loss of sensation, and unfortunately, since a lot of times this happens when you're really young, symptoms get worse as you grow up. Sometimes people don't even have symptoms when they're a child, but as they go into adulthood and it hasn't been diagnosed yet, then the symptoms can get really bad and continue to get worse. And that extra flexing and stretching from having that spinal cord pulled on can make things worse and sometimes cause permanent damage. So it's really important for that to be evaluated and treated as early as possible. Other types of things or symptoms can include movement disorders, such as uncontrolled muscle contractions or spasms, twitching, jerking, fidgeting types of movements, and tremors. Another thing that's unfortunately more common in folks who have EDS is a Chiari malformation. So a Chiari malformation is related to the brain, and it actually has to do with the tissue around the brain stem. So you'll notice this with the brain stem and the cerebellar tonsils, which is kind of like the lower mini brain in the brain. And it kind of gets pulled down or is too low, and therefore there isn't a space where the fluid actually should be going back and forth and flowing. So it causes what they call obstruction, which is the lack of ability for the movement to go back and forth. So when the fluid can't circulate, then it can actually flatten the pituitary gland, which leads to hormonal changes, or it could lead to lots of other signs and symptoms, actually kind of similar to tethered cord and sometimes similar to craniocervical instability. And you'll notice with a lot of these syndromes or diseases, there's a lot of overlap in symptoms. So I personally find it very challenging to figure out what's what. So for example, they think I have craniocervical instability and atlantoaxial instability, possible Chiari malformation, and possible tethered cord. And I'm looking at them and saying, they all look alike if you look at the symptoms, so how in the heck do you know what's what? Could it be that I have craniocervical instability and maybe tethered cord, and that's pulling on the brain because it's pulling on the spinal cord? I don't know. We'll find out, and I will keep you guys updated, but I personally find that pretty challenging. Luckily, I'm not an MD, so I don't have to worry about it. Idiopathic intracranial hypertension, or what they call pseudotumor cerebri, is another thing that is more common to happen in EDS. It's not only found in EDS, but it's more common to find it in these folks. So that happens when there's an increase in the cerebrospinal fluid pressure under the skull. So it's not like a normal pressure hydrocephalus or anything like that. There's just too much fluid pressure in there. And since it's kind of like you're in a room with walls and you're trying to put too much in the room and you're pushing and pushing and pushing on those walls, and the walls aren't going anywhere, much like that's a lot like in the skull where, okay, there's the brain and now there's too much fluid pressure. Where's it going? So you can have symptoms like headaches, visual disturbance, light sensitivity, tinnitus or the ringing of the ears, nausea, vomiting, visual difficulties, and unfortunately some people can develop blindness. And I've actually seen patients myself who have cognitive difficulties from this. Mast cell activation syndrome is something that I'm not going to get too much into because I'm only starting to learn about it myself. And I truly don't feel very qualified to talk about it, but this is kind of a full body thing that can affect the GI tract, the skin, and kind of the upper respiratory system as best I can really tell. So it's something with the mast cells in the body that tends to affect different things and can lead to abdominal pain, diarrhea, upper respiratory stuff. So that if I have MCAS or mast cell activation syndrome, that could be why I had all of the itises as a child, the otitis, the sinusitis, bronchitis, because the mast cells just make it so that you get sick more often. You can also have itchiness and redness and damage to the skin, but there's just so much more. And honestly, I just don't feel competent discussing too much of it. Other things that can happen are, and this is something I'm not really too familiar with, but a Tarlov cyst syndrome, which are little fluid-filled sacs that develop near the spinal cord. And again, like the brain, there's only so much room places. So when they happen, it can actually put pressure on the neural structures around that. So that can lead to bowel and bladder control problems because it's down there near that area, and also pain. That is something that usually can be treated. There has been some association with attention deficit disorder and autism, although I don't really know a lot about the cause or why that might be. And some of the other symptoms that one could experience is muscle pain in addition to the joint pain, nighttime muscle cramps, especially like Charlie horses in the calves, low tone, it's kind of like floppy muscles, and muscle weakness. So a lot of stuff. And again, most people don't get all of those things. Usually get a subset of symptoms, and it's really, really dependent on the specific type of Ehlers Danlos that you have. And as you can see, there's so much overlap with other unrelated diagnoses that it's really hard for people to pick up on. I mean, it's different, whole different systems in the body. So, when I was trying to get diagnosed, I saw sleep doctors, I saw dentists, I saw pain management doctors, I saw rheumatologists, I saw doctors for urinary issues. There were so many, I saw a heart doctor, I saw a dermatologist. Well, if they're only looking in their area, they may only find that thing, which they may not be able to say, oh, this is EDS, because they may not be very familiar with it. And if you don't go in saying, this is the laundry list of what I have, which nobody does, then they might not connect the dots. As I've alluded to before, the cause of EDS is genetic. So there are a small minority of cases that are not inherited. Some actually do occur because of spontaneous gene mutations, but usually it's more genetic. And again, with hypermobile type, we just don't know what that gene is yet. So how's it diagnosed? Well, In my case, you just search and search and search for 30-something years and eventually you find the right doctor. But no, that's not really it. So I'm not sure if it's the Beighton score or the Beighton score. I thought it was Beighton, but one of my doctors said Beighton. Either way, Beighton. And that's something that was created not necessarily for EDS, but just to assess joint hypermobility. Unfortunately, this leads to difficulty with diagnosis because it's not assessing all of the joints. It's assessing, can you put your hands flat on the floor while bending over without bending your knees? Can you bend your pinkies back more than, I think, 90 degrees? Same thing with the thumbs. If you straighten out your arm, are you able to bend it more than what it's supposed to be? And same thing if you're hyperextending your knees. So that doesn't account for shoulders. That doesn't account for knees itself or ankles or, necks. So there are things that you're missing. So a person may end up getting underdiagnosed because of that. However, that's one of the things that they have. So that's something that they look at. They also look at your medical history for other types of syndromes or conditions associated. One of the things that they do is look at family history to see if it's inherited. I personally have a problem with that because this is such a poorly understood condition and it takes so long to diagnose. And for those who are adults now looking at parents and grandparents, it may never have been picked up. They may just have said, oh, I have pain. The end. And you don't know. So that one is a little bit problematic. A really good way to do it is actually to do genetic testing because that way you can look for specific genes. But in my case, they looked at 50-something different genes and nothing came up. And again, that is what will happen in hypermobile EDS. We just don't know all of it yet. They'll also look at the major criteria and the minor criteria, which look at little smaller things to see, this is associated with EDS. And if you have X amount of them, it's likely that subtype of Ehlers Danlos. The prevalence is right now, it is thought to be a rare disorder, but it is underdiagnosed for sure, and it's very hard to diagnose. So we don't really know how rare it is, but it's thought to be 1 in 2,500 to 5,000 people. It occurs in people of all races and ethnicities, and we don't really know how common it is in males and females just because we're not seeing as many males. But it seems to be more common in females, but we really don't know that for sure. And as I mentioned, it is often inherited, and because it's autosomal, it can be either autosomal dominant or autosomal recessive, depending on the type. Now, for treatment, there isn't a particular treatment that will make it go away. It's really symptom management and associated syndrome management. So a lot of times there's some sort of medication, surgery, although you have to be very, very, very careful the reason and the person and the area. Physical therapy is huge. There could be, they look at ways to maintain independence. So are there types of equipment that a person needs, like a wheelchair or a walker or a cane? Or do you need braces? So right now I've had a really bad flare-up, so I have a brace on my left ankle, both knees, both wrists, my SI joint, and my neck. But some days I don't need that. So it's really looking at what does that person need to be more independent and to improve their quality of life. Other things like lifestyle adjustments like sleep management as best you can, rest and relaxation are good, although we know that sleep architecture for folks with EDS is really not great. So you can really only do so much. A lot of it is seeing the different types of doctors for the different types of things. So dermatologist, if need be, dermatologist or allergist. If you have something like MCAS, you can see a GI specialist, depending again on what you need. So I could be listing treatments all day, and it will just depend on what you have because everyone is so different. Lastly, the prognosis is different for each person. For most types of Ehlers-Danlos, the life expectancy isn't affected, but for the vascular type of Ehlers-Danlos, there is unfortunately a shortened life expectancy, sometimes in the 30s and 40s for those individuals, just because they have a higher likelihood, or actually a pretty high likelihood, of organ and vessel rupture. So that's kind of the lowdown on Ehlers Danlos syndrome. I will link people up to a lot of great resources where you can get more information. There's a helpline, a bunch of support groups, and there's this really great e-magazine from the Ehlers Danlos Society called Loose Connections. And I got a chance to read through it yesterday, and it has different art from people who who have Ehlers-Danlos, also known as zebras. It also has stories and poems and resources, so it's just a really wonderful resource for people to have. Anyway, thanks for listening. That's it for our show. Join us next time on The Spoonie Struggle. Well, that's it for our show. To find out more, join us at www.spooniestruggle.com. That's Spoonie, Spoonie. Check us out on Twitter, Facebook, and Instagram at The Spoonie Struggle. Please help us out by giving us 5 stars on iTunes and leave us a review so fellow Spoonies can find out what they like about us and discover their community in which to thrive. See you next time on The Spoonie Struggle.